Hi, my name is Amy Bray and I'm a Senior Therapeutic Radiographer specialised in the treatment of paediatric and teenage and young adult patients at Leeds Cancer Centre in the UK. I share the role with my colleague Emily Westgarth and she's helped me in the production of this presentation. Leeds Cancer Centre is based in Yorkshire in the UK. It's a large centre comprising of 12 elector linear accelerators, 3 CT simulators, 1 MR simulator, which has recently been installed and is in the final stages of testing before it goes live in the next few weeks, a stereotactic radiosurgery or gamma knife unit, brachytherapy theatres, and a large staff consisting of 134 therapeutic radiographers, 28 dosimetrists, 35 physicists, 40 doctors, 24 engineers, 16 administrative staff, and 5 nurses. The total number of patients treated last year in 2022 equalled 7,600, and that was ranging from a single treatment right up to 35 sessions of radiotherapy or more. So, of the 7,600 patients we treated last year, only 44 were paediatrics, who were either treated with external beam radiotherapy, total body irradiation, or stereotactic radiosurgery. We referred 23 patients from our area for proton beam therapy at other centres. Most of the children we treat under 6 years old require a GA, or general anaesthetic, for simulation and for the duration of their treatment. It's worth mentioning that any patients under the age of 25 falls under the care of the paediatric team here in Leeds. And also some of our patients are on concurrent chemotherapy when having their radiotherapy, so they're juggling 2 sets of appointments and the side effects of 2 different treatment modalities. So even though we treat a small percentage of the patients coming through the centre here in Leeds, we do have our own staff comprising of 2 consultant clinical oncologists, 2 therapeutic radiographers, 2 nurses and a play specialists. The children also have their own area within the department where they can come with their families away from the adult waiting areas. Here they can play with toys, watch TV or enjoy making some crafts. We also have a chill out room for the teenagers and young adults where they can watch TV or play on a games console. So we don't treat all and any cancers with radiotherapy. Some are radiosensitive while others aren't. Here are some of the main diagnoses that we treat. Primitive neuroectodermal tumours or PNET, such as ependymoma or medulloblastoma, rhabdomyosarcomas, Ewing's sarcoma, Wilms tumours, neuroblastoma, leukemias either focally or systemically, lymphomas, again focally or systemically, so if there are any deposits which may benefit or be eradicated by radiotherapy, they can be treated. Diffuse intrinsic pontogliomas, DIPGs, palliative patients in a symptom relief capacity. We also can treat rarer cancers if they're amenable to radiotherapy, such as clear cell tumours or synovial sarcomas. We also treat some malignant, although still life-threatening conditions, such as sickle cell anemia and anaplastic anemia. We use different techniques depending on the intent and complexity of the treatment. We use BMAT or arc therapy, which uses a rotating beam and moving multi-leaf collimators to conform to the treatment target. DMLC or dynamic MLC treatment uses a static beam but moving MLCs. When MLC treatment uses static beams and static MLCs. We also have a TBI, which is a systemic treatment where the entire body is irradiated. We have a stereotactic radiosurgery, not delivered by the LINAC, and it's used to treat very small brain lesions. And tumours that meet the referral criteria are sent for proton beam therapy in either Manchester or London. Some of these tumours that qualify include some Ewing sarcomas, some rhabdomyosarcomas, some ependymomas and some medulloblastomas. And it's all dependent on the strict criteria outlined by the NHS commissioners. So, paediatric treatment protocols and guidance are very strict and are directed by national and international guidance. There are also panels of expert clinicians that discuss cases which don't fall neatly into the published guidance, which is often the case with paediatric tumours, as they are rare and complex in nature. The guidance followed by clinicians stipulates the dose and fractionation regimens, maximum allowed dose to organs at risk, treatment techniques used, and the timings of the treatment alongside any concurrent or chemotherapy or surgery, as well as lots of other very strict and stringent guidance. And here is a list of the protocols used by clinicians when planning paediatric treatment. So here we have an example plan. It's a 2-year-old little boy. He's treated under general anaesthetic for a left-sided Wilms tumour, which has been surgically excised. And he also had a single metastasis in the lower left lobe of the left lung. Here the areas in red are representative of the high dose areas to the primary tumour, and the blue area shows the dose received by the whole lungs. This little boy was treated with VMAT, and I've just highlighted some areas of interest. Here we can see an area of high dose delivered to the entire tumour bed, which is the site of the primary disease. We can also see high dose in the lower lobe of the left lung, which was the site of the sole metastasis. Because this child had disease spread to the lung, treatment protocols stipulate he should receive radiotherapy to the whole lungs to minimise the risk of further disease within the lungs. This boy also had a left-sided nephrectomy as part of the surgery to remove the primary tumour. So we can see here that the beam is being shaped around the right kidney to ensure minimal dose to this area and thus to preserve function. Another point of interest can be seen in this image. The view is from the posterior aspect, so it looks the opposite to the previous image, but you can see here again the shielding of the right kidney. You can also see how the vertebrae, outlined in green, are being irradiated symmetrically. That is, the whole of the vertebral body is receiving the same dose throughout. This has been done deliberately to prevent the uneven growth of the bones. So radiotherapy can impair growth. If only one side of the vertebral body were irradiated, in this case it would be the left side, then the left side of the vertebral body would grow slower than the right side, which could lead to the curvature of the spine in later life. Symmetrical irradiation of the vertebral bodies is stipulated as a requirement of treatment planning in the guidance for clinicians. So here we have an example of a whole CNS treatment for the brain and spine. This is an 11-year-old boy, also treated under GA, who had a medulloblastoma. And again, the high dose is shown in red. This treatment poses challenges in that the treatment field is too long for it to be encompassed in a single treatment field, as the machine can only expand to a length of 40 centimetres. We will therefore create a plan with a feathered border, that is, the point at which the two fields join changes each day to ensure no consistent gap or overlap, thus eradicating the possibility of under or overdosing the spinal cord. We can also see here the symmetrical irradiation of the vertebral body, and we can see a steep dose drop off as we move away from the spine, which reduces dose to healthy tissue. At Leeds, we also offer total body irradiation. It's used usually in conjunction with high dose chemotherapy, and it essentially kills off the patient's existing bone marrow, ready for them to receive new bone marrow, which will hopefully cure their disease. It's a systemic treatment used to assist in the treatment of leukemias and lymphomas, as well as benign diseases such as sickle cell anemia and anaplastic anemia. Total body irradiation and the other conditioning treatments used for preparation for bone marrow transplant carry great risks, including infertility, depleted blood counts, infection due to the depleted blood counts as it impairs the immune system, and risk of death from infection. Therefore, these patients have to be isolated when visiting the department to minimise contact with others and therefore reducing the risk of contraction and infection. Radiotherapy treatment can cause lots of side effects. Day to day, I help patients manage acute side effects, including skin reaction. The skin can turn red and itchy like a mild sunburn. Topical moisturisers, barrier creams and dressings can help in managing this. Fatigue. The patient should drink plenty of fluids and rest when needed. Change in bladder or bowel habits. Loperamide can be prescribed for diarrhoea, tamsulosin for cystitis. Nausea and vomiting. Antiemetics can be taken, such as ondansetron, metoclopramide or cyclizine. Depleted blood counts due to irradiation of bone marrow, particularly in treatments of large areas such as the CNS, where a large volume of bone marrow is irradiated. And this can be helped by blood transfusions. Long-term side effects include growth impairment, infertility, somnolence, impaired cognition, and secondary malignancy. These are all monitored closely at long-term follow-up clinic. Most children, aged 6 and under, require a general anaesthetic for radiotherapy planning and treatment. Although in the past we have gotten a 3-year-old patient through treatment awake with a lot of preparation. We'll also anaesthetise older patients if it's necessary, such as those with learning difficulties. We don't have a GA team in-house, so they come over from Leeds Children's Hospital for the patient's treatment. Patients are fasted in preparation for GA daily. Most patients are anaesthetised with propofol via pre-existing access such as a portacath or a Hickman line, but we can do a gas induction if necessary. And this is done in the radiotherapy treatment room. The GA team leave the room during treatment to avoid radiation, and they monitor the patient via CCTV. We have a recovery area in the Paediatric Radiotherapy department where the patient is moved to after treatment to wake up. And before the patient is allowed to leave, they need to eat and drink. We have a stock of goodies the children can help themselves to, such as biscuits, cereal and juice. Avoiding the use of GA is better for all. It reduces the use of hospital resources, it's cheaper, and it's better for the health of the patient. So here at Leeds, we do all we can to get our patients through their treatment awake. Some of the tools we use are the little linac. This is a miniaturised version of the linac that was built by our engineers. The children can move the linac around and get a feel for how the linac will move. We have the magic string. It's a long string, it's very colourful. The patient holds one end and the parent can hold the other, so they can feel connected to their parent or guardian while they're not together in the same room during treatment. We also paint the masks for the children, any character or theme that they'd like, just to add a bit of fun to the wearing of the mask should they need one. We give sticker charts so they can count the days off, how many treatments they've got. We also give them power stones. Again, this is a tool for them to feel connected to their parents. The patient has one stone in which their thumbprint is depressed in it, and the parents have another, and they both hold them during treatment. We give them prizes if they've stayed especially still or at the end of the week, and all the patients get a present at the end of treatment. We can offer music. We can play it in the the treatment room during their radiotherapy. Beads of courage. A different bead is given to the patient for each different part of treatment they overcome. So there's a bead for a radiotherapy appointment, there's a bead for bloods, there's a bead for seeing the doctors, and each bead represents a different clinical procedure. We can give them a stress ball or fidget spinner. We can chat to them over the intercom, tell them how long is left of their treatment. We can let them watch movies or TV shows on the iPad. And that special arm there just attaches to the bed, so we can angle the screen over the children. We also have Lego Linacs. This is a display one of the radiotherapy room, but we also have smaller ones that we give to the patients to take home. And we also have the end of treatment bell that they can ring at the end of the treatment. This is by no means an exhaustive list, and I could do an entire presentation on paediatric patient preparation and the tools we use. So if you have any questions about them or want any more information about it, please feel free to email myself or Emily Westgarth, and we'll be happy to chat some more about it. I'd just like to stress that support really is key when these families come for treatment. It may seem like we devote a lot of time and resource to such a small minority of patients, but please remember that these people have received a most devastating blow. To have a sick child who may die is a burden only the unlucky few will ever have to carry. So I think we owe it to them as healthcare professionals to provide the most supportive and comprehensive service it is possible to achieve. We are not just strangers in white tunics to these children. We are a primary and key source of information, a referrer to other services. We offer advice on side effect management. We offer emotional support. We are a friendly face. And most of all, we are an advocate for these vulnerable patients. So thank you very much for your time and for listening to my presentation today. And please do ask any questions you might have.